Hello, I'm Yuho Najima from Tokyo Metropolitan Komagome Hospital in Japan. Thank you very much for your kind introduction. It is a great honor to participate in this great meeting. Today I will talk about how we can optimize the allo transplant in acute lymphoblastic leukemia. This is my COI. So let me first outline today's presentation. I will begin with the current role of allogeneic transplantation in ALL. This is a result of a large-scale database in Japan revealed dismal outcome of the patients with their first relapse of Ph negative ALL. After the first relapse, 5-year overall survival is 16.3% with conventional chemotherapy. If CL2 is achieved, OS will be better in the patients with allo-HCT. These data are from a large Japanese cohort, registry cohort from other ALL patients undergoing allogeneic transplantation. Outcomes of allo-HCT have been improved over time from 1990 to 2090. So, in recent years, overall survival rate exceeds 70% at 5 years for patients transplanted in CR1. However, outcome remains poor in patients transplanted in non-CR. This highlights the remission status that transplantation is the strongest predictor, underscoring the importance of achieving and maintaining remission. This is a large Japanese nationwide cohort of Ph-positive ALL undergoing allo-HCT, looking at overall survival. The blue line represents CL1 with MLD negativity showing the best outcomes, over 70% survival. In contrast, red line CL1 with MLD positivity already shown inferior survival. The same pattern is observed in CL2. CL2 MLD negative, depicted in green line, performs better than the orange line, CL2 with MLD positivity. Importantly, when we look at the relapse incidence on the right, this difference is particularly pronounced in CL2. It's around 50% relapse rate. So this MLD positivity is associated with a higher relapse risk. Achieving MLD negative remission before ACT is absolutely critical. So outcome after allo-ACT in ALL in non-CL patients were extremely poor. 2-year OS was only 17%. When we performed the multivariate analysis, we extracted risk factors including bone marrow hypercellularity, elevated LDH, and not in primary induction failure status at transplant. Based on these factors, patients were stratified into risk groups, but even in the group risk group, 2-year OS was only around 27%, while there were almost no survivors in poor risk group. Therefore, achieving remission before transplant is absolutely essential to improve outcome after transplant. So the next question is how to achieve deeper remission before transplant, bridging strategy and MLA. This slide summarizes the overall treatment strategy across the transplant course. RHCTD should not be considered as a single event. Rather, it is part of a dynamic and a continuous process. Bridging therapy aims to achieve deep remission, ideally MLA negative remission. Conditioning provides a transient but powerful anti-leukemic effect. Post-transplant maintenance treatment bridges the gap until a durable graft versus leukemia effect is established. So the Bernat-Mobab improves overall survival compared with chemotherapy. Also, it achieves higher CR rate and importantly, high rates of MLD negativity among responders. So overall, it is very effective bridge strategy for transplant. And the noticeable vasoconstriction achieve a high CR rate over 70%, and about 80% responders achieve MLD negativity, facilitating transition to transplant even in high tumor burden patients. However, SOS risk increases with repeated cycles, so it is usually limited to 2 cycles before SCT. Here I directly compare Brennan and Eno. Brennan is MLA directed and achieve deeper molecular remission, especially in low disease burden. In contrast, Eno is cytoreductive with high CL rate and rapid tumor reduction, making it suitable for high disease burden. However, Eno requires caution due to SOS risk, so cycles should be limited. Therefore, these agents are complementary. Selection should be tailored based on disease burden and MLD status. So this is our institutional cohort of 70 patients with ALA-BALF, one of the first ALA-ICT after salvage therapy. The complete remission rate before transplant was significantly better in patients treated with antibody-based treatment compared to conventional chemotherapy. So antibody therapy actually increased the likelihood of achieving CL before SCT. Overall survival and disease-free survival were significantly better with inorbulin compared to standard chemotherapy. However, these differences disappears in patients who were already in CL before transplant. This indicates that benefit comes from achieving CL before transplantation, consistent with non-CL being the strongest adverse factors in the multivariate analysis. So remission is key, but relapse remains. So post-transplant maintenance to sustain remission. So this figure illustrates the disease burden after HCT, with or without post-transplant maintenance. Conditioning rapidly decreases the disease burden, while GVL effect takes around 6 months to fully develop. Thus, relapse may occur early, around 6 months after transplant. So maintenance therapy provides an additional anti-leukemia effect, bridging this gap between conditioning and GVL, preventing relapse until GVL is established. So maintenance treatment provides the additional third anti-leukemia effect. There are 2 types of post-transplant maintenance. First, preemptive therapy, which is initiated when MLA becomes positive. This approach avoids overtreatment and avoids unnecessary toxicity, but may miss diseases which is below under the detection limit and carry the risk of rapid relapse. Second, prophylactic maintenance, which is given even in MLD negative status. This can suppress fragility of disease, but at the cost of potential overtreatment and a possible interference with immune reconstitutions. So the key question is how to balance these two approaches. So there are similar requirements for maintenance after allo-HCT. After transplant, there are severe difficulties including a weak immune system, damaged organs, and insufficient hematopoietic recovery. So ideally, maintenance therapy should be effective, less toxic, and minimally immunosuppressive while preserving the GVL. And ideally, it's easy to administer. Traditionally, hypermethylating agents and FLT3 inhibitors for myeloid malignancies and TKIs were used for Ph-positive ALL. Recently, antibody-based therapies, including Brina and Inner, have emerged. However, these are intravenous therapies and not necessarily easy to administer, so they do not fully meet these ideal criteria, although promising data are accumulated. According to the NCCN guidelines for Ph-positive BAL, post-transplant TKI maintenance is recommended when feasible. In addition, MLD plays a key role in treatment decision making. When MLD is positive, persistent, patients are not directly taken into transplant. Instead, further treatment such as blinatumomab is recommended to achieve deeper remission. In other words, MLD serves as a decision point that guides the treatment strategy. So how should maintenance strategy be optimally integrated into clinical practice? This slide summarizes post-transplant TKI strategies in Ph-positive ALL. Risk stratification is based on MLD status and TKI resistance or mutation status before transplant. Patients with MLD positive or high-risk features are considered high risk, and in these patients, prophylactic TKI, preferably with second generation TKI, is strongly recommended. In contrast, low-risk patients, an MLE-guided preemptive approach is often preferred. The typical duration of TKI maintenance is around 6 months or 1 year after achieving MLE negativity, although the optimal duration remains unclear. Importantly, while second-generation TKIs are generally used, evidence for third-generation TKIs in the maintenance setting is still limited. This is the current recommendation for post-transplant maintenance for Ph-positive ALA in Japan. First, risk-adapted strategy based on MLD and pre-transplant risk is essential. Second, second generation or later TKIs are preferred, typically starting from low dose. Third, treatment is continued for at least 6 months, and discontinuation may be considered after sustained MLD negativity for 2 to 4 years. However, the optimal strategy and duration remains unclear. Here's real-world evidence for polygen maintenance after RACT. A single-center study from Japan showed that low-dose polygen 50 mg started early after transplant improved leukemia-free survival, with a favorable trend in molecular relapse-free survival. Prophylactic polygen maintenance may improve relapse-free survival. A multi-center cohort from Italy demonstrated that prophylactic polygen achieved better relapse-free survival than a preemptive strategy, with overall survival over 90%. Taken together, polygen maintenance may improve disease control after RHT, and the earlier intervention appears more effective than MLD-triggered strategy. Here is shown our institutional data on post-transplant TKI use among 225 patients who underwent first RCT and HCL. 43 received post-transplant TKI. These were divided into preemptive and prophylactic strategies, focusing on ponatinib. 15 patients received preemptive ponatinib, triggered by MLA positivity, while 9 patients received prophylactically. Importantly, in both groups, ponatinib was studied under clinically challenging conditions. In the preemptive settings, 13% had active GVHD and 80% were on immunosuppressants with their median stat around day 111. Similarly, in the prophylactic settings, 11% patients acute GVHD and nearly 90% were on immunosuppressants and with the slightly earlier median stat around day 100. So in the preemptive group, discontinuation rate was significantly lower with ponatinib compared to dasatinib. Importantly, no discontinuation due to toxicity occurred in ponatinib group. Only one patient got retinal arterial occlusion in ponatinib group. It was manageable with dose reduction. This suggests better tolerability and treatment continuity in ponatinib group. Next, we evaluated efficacy in the preemptive setting. Median duration of TKI days were longer in ponatinib. Molecular remission rate was almost the same, around 80%, and overall survival was comparable between the two groups with no significance. Relapse rate was almost comparable, but ponatinib showed a lower cumulative incidence, although the differences did not reach statistical significance. Importantly, no relapse mortality was 0% in both groups. Next, we evaluate discontinuation rate in a prophylactic setting. At 2 years, the cumulative discontinuation rate was lower in ponatinib at 22% compared to dasatinib at 75%. The main reason for discontinuation was pulmonary complication, including POS and OP. One patient in the ponatinib group developed liver damage with elevated troponin T. This slide summarizes the efficacy in the prophylactic group. Although the dasatinib group was only 4 patients included, the median duration of TKI was longer in ponatinib. Overall survival at 2 years was not different, and also the relapse rates were comparable between the two groups. No non-relapse mortality was observed. Taken together, ponatinib shows good feasibility and treatment continuity after RSCT. This slide shows the NCCN guidelines for Ph-negative BALL. Allotransplant is clearly indicated, particularly in patients with high-risk features. However, there is no specific recommendation for post-transplant maintenance. In other words, maintenance is not well defined in Ph-negative AL, unlike its standard use in Ph-positive AL. This is a phase 1-2 study from Japanese evaluating post-transplant maintenance with brentuximab. The study included pediatric IR patients with relapsed and refractory BAL after RSCT with a median age of 10 years. Brentuximab was initiated between day 30 to 100 after transplant and administered for 2 cycles. As shown here, treatment was generally feasible and most patients were able to complete therapy. terms of safety, toxicities were manageable, mainly cytopenias with limited CLS and acceptable DVHD profiles. Importantly, all evaluated patients achieved MLD negativity, and notably there were no relapse or deaths within 1 year in this cohort. This is a phase 1 multi-centered study evaluating low-dose inotuzumab as post-transplant maintenance. This study included high-risk ALL in CL after LSCT, and inotuzumab was administered between day 40 to 100. As shown here, both overall survival and progression-free survival appears favorable, with 1 year PFS of 89% and overall survival of 94%. Similarly, clearance was observed in this subset. Low-dose INO may provide a feasible prophylactic maintenance strategies. So finally, I will move on to novel conditioning approaches. So MLD appears to be your key driver of relapse after transplant. How MLD persists even after achieving CL, residual leukemic clone can persist, and over time, these MLD clones may evolve into therapy-resistant self-clones. Where MLD persists, resistant clones persist into bone marrow niche. They remain in quiescent status, which makes them less sensitive to conventional chemotherapy. From clinical perspective, molecular relapse typically precede hematological relapse, indicating that disease progression beginning at the subclinical level. In most cases, this expansion originates in the bone marrow and lymphoid tissues. Taken together, these findings suggest that targeted bone marrow and lymphoid tissues may help reduce relapse while limiting toxicities. I would like to highlight the impact of conditioning intensity. Based on the Japanese registry data, in the conventional CYTBL12 gray group, MLD positive patients had worse outcome with inferior disease-free survival and a higher relapse rate. In contrast, when BP16 was added, these differences between MLD positive and negative patients were disappeared in disease-free survival and also in relapse rate. This suggests that intensified conditioning regimen may mitigate the adverse impact of residual disease. What is the rationale for increasing irradiation dose? First, in randomized study in AML5 cleft, higher TVA dose significantly reduced relapse, but this did not translate into overall survival benefit due to increased non-relapse mortality. Similarly, in ALL, studies by Merck showed that in CL2 patients, high-risk patients, higher TVA dose more than 13 gray reduced relapse, particularly in high-risk disease, but at the cost of increased MLM. To overcome high-risk disease while keeping MLM low, we need to optimize conditioning intensity. The conventional MAC provides strong anti-leukemic effect but at the cost of toxicity. Therefore, the key question is how to enhance anti-leukemic activity without increasing MLM. One potential solution is total marrow and lymphoid irradiation or TMLI, which allows targeted intensification of conditioning. In our With the introduction of TOM therapy in 2018, we became able to deliver total body radiation using intensity modulated radiation therapy or IMRT. This allows us to reduce the dose to critical organs such as the eyeballs, lungs, and kidneys, while maintaining the adequate dose to the target tissues. In other words, IMLT enables precise organ sparing dose distribution. This technological advancement forms the basis of TMLI. Compared with conventional TBI, TMLI maintains anti-leukemic effects, including leukemia eradication, immune suppression, and engraftment, while notably reducing late toxicity. This is achieved by selectively delivering radiation to the marrow and lymphoid tissues while sparing normal organs using the IMLT-based technique that enables dose intensification with less toxicity. Here, radiation is precisely delivered to the skull, sparing normal tissues. So in the chest, lungs is spared. In the abdomen, normal organs, including guards, are also protected. So this is striking results from the TMLI study by City of Hope. TMLI was delivered at 20 gray at 4 gray per day over 5 days, representing intensified conditioning. All patients were transplanted in non-CL, yet 2-year survival reached around 40% with low non-relapse mortality. This is quite remarkable for such a high-risk population and supports TMLI as a strategy for safe intensification. So after learning the technique from City of Hope we visited there, we implemented TMLI at our institution and conducted a phase 1 study of TMLI MAC. All patients were in CL and the high-risk diseases, and 7 out of 9 were MLD positive, and all of them are CL2. Non-DLT by day 100, OS over 80%. Non-relapse mortality was 0% at 1 year, and 3 of them relapsed, and 1 alive after the second transplantation. Though the recommended dose was at 18 gray over 3 days, which is biologically equivalent to approximately 21 to 23 gray over 5 days, representing a highly intensified conditioning regimen. The slide shows our ongoing phase 2 results with TMLI 18 gray. 1 year OS was 78, cumulative instance of relapse was 21%, and non-relapse mortality was 7%. So all patients were high or very high risk by refined disease risk index, where historical 2-year OS is usually 20 to 30%. These results suggest that TMLI may improve outcome by reducing toxicity while preserving or enhancing efficacy. So what is the next step? In City of Hope, TMLI 12 gray over 3 days combined with fludarabine and melphalan for leak-eligible high-risk patients. All of them were in non-CL. Despite these high-risk features, early mortality remained acceptable, and 1 year OS reached 75%, with a plateau observed in long-term follow-up. Based on these results, it is promising, so we have initiated a phase 1 TMLI leak study at 9 gray per 1.5 days. It's also ongoing. It is 10 gray equivalent conventional fraction. In summary, optimizing allotransplant in ALL requires continuous MLD-driven strategy. Before transplant, achieving deep remission, ideally MLD negative, is critical. After transplant, relapse prevention through MLD-guided and prophylactic maintenance becomes essential. And importantly, conditioning approaches such as TMLI may enhance anti-leukemic efficacy while limiting toxicity. Taken together, allo-HCT should not be viewed as a single event but as a continuous and integrated treatment strategy. This approach may ultimately improve outcomes even in the high-risk ALL. Finally, I would like to acknowledge all my colleagues and collaborators for their continuous support. Thank you very much for your attention.